What I'm going to talk about at their request is a title that was an editorial I had in the British Journal of Anesthesia, which is Applied Cardiopulmonary Physiology in the Theater, which has to do with just a practical application. This is a complete change from the last lecture in which we talked about pharmacokinetics. I'm not going to talk about a single inhalational anesthetic at all. The only anesthetic I'm going to be discussing is an intravenous one, and so I'm going to avoid that. In America, you have to show your conflicts of interest, and these are my important conflicts of interest. These are my family, my wife, who some of you met last night, and my 3 children. These are my unimportant conflicts of interest. By the way, I've been a consultant to every known hemodynamic monitoring company. Our University of Pittsburgh has several patents that I'm the inventor on, but they own. That's how the universities work. But more importantly, my true conflicts of interest, I've got 3 grants, and 2 of which are on machine learning approaches and biological signals, for which I'm the PI of those R01s. But these are the future of where we want to be. What I want to do is give you a different perspective on cardiovascular physiology and show you how something old, something new, and something borrowed can work for you in the ICU, in the OR today. And this is examples from the operating room that allow you to understand the physiologic state of your patient. And what we're working on today, and I expect to have in the next few years, but no more than the next few years, your ability to accurately predict what will happen in the future in your patients so you can treat them before it happens. Okay. When we talk about hemodynamic monitoring, wherever you are, we have these non-invasive, invasive factors, and you can put in these catheters all you want, but if you don't use the information properly, you're just showing screens, and it's very nice, but it's a waste of time. And the reason I'm saying this is because without an understanding of the physiologic basis of what's going on, you miss it. And let me give you a concrete example. There is no relationship between CVP or its change or pulmonary occlusion pressure and its change with the fluid bolus and the change in cardiac output. So if you use either of those 2 measurements, CVP or wedge pressure, to see if your cardiac output will increase if you gave fluids and look at the change, they're not related. And I would argue they shouldn't be. Furthermore, in a study that was done by Kumar et al., they looked at all variables they could in patients who were in shock that they were resuscitating, and there was no relationship between CVP or the change in CVP and right ventricular end-diastolic volume where it's changed, and the same for wedge pressure, the change in wedge pressure, and left ventricular end-diastolic volume. And that was true if you ignored the volumes and just said stroke volume, there was no relationship. There has never been a study that has shown there is, but we don't even think this. The reality is, and if you learn nothing else from these first 3 slides, please learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive. The most common form of heart failure today is diastolic dysfunction with preserved ejection fraction, right? Small heart, but give that person volume, and they go into pulmonary edema. So we have to rethink this. Do we really? Not really. We knew this 100 years ago. ANRAP described this in the same laboratory as Ernest Starling. Starling didn't like ANRAP. ANRAP was German and Russian, and so he published his stuff at the exact same time, in the exact same years, in the German literature. It took us a few years to get over it. But if you read the journal Cardiology, any month there will be an article on the ANRAP effect and the article on Starling's Law of the Heart, because in both cases we do not know the molecular mechanisms, but we knew the ANRAP effect a little better. This slide is from a paper in 1959, not because we didn't know it until 1959, but this was a pretty picture. This is an isolated human heart, totally denervated, in a circulation. And what you can see to start with is this is the volume in the ventricle, and there from the top down is the stroke volume. The heart gets smaller, the volume gets smaller. And if you simply increase the pump to get more fluid back into the heart, you see an immediate increase in stroke volume as the end-diastolic volume goes up. That's Starling's Law of the Heart. Okay? You all feel good about that. But watch. Over a period of approximately 2 minutes, the stroke volume remains elevated. It's still very high, That's the ANRAP effect. And if you note, you're at a lower end diastolic volume than you were before. So if I measured 3 minutes after giving a volume bolus and the cardiac output goes up, the preload, it's actually lower. So I should never expect them to be related to each other. And by the way, everyone in this room knows this is true from your own personal experience. Is anybody here a bicyclist or a jogger? Okay, so when you get on your bicycle or jog and you've gone the first 20 meters or 100 meters if you're good, you know you've made a mistake. You feel terrible, don't you? Okay, but you've already done this once before, so you keep going. And after about another 30 seconds or so, you start thinking of totally other things and you ignore. Why? Because the juices are now flowing. Your ANRAP effect is kicked in, and your cardiac contractility is normal. So this is the reality that the world we live in. So now let's take a look at the global interaction between volume, flow, and contractility. In this graph, using a computer simulation called Symbiosis, I simply plotted for a 70-kilogram, 24-year-old male the solution that would give me a mean arterial pressure of 80 millimeters of mercury for a given systemic vascular resistance. EH is cardiac power, and PMS is mean systemic pressure, which is the effective circulating blood volume. And this is the solution that I would get for varying contractility, resistance, and tone. And as you can see, I can have heart failure, hypovolemia, or sepsis with a mean arterial pressure of 80. So knowing that the mean arterial pressure of 80 tells me that the mean arterial pressure is 80. It doesn't tell me anything else. I can do the exact same solution for a cardiac output surface in this person of 5 liters. And again, I can have heart failure, sepsis, or hypovolemia for a cardiac output of 5 liters. So knowing the cardiac output is 5 liters doesn't tell me anything about my patient. Well, what if I add the two together? For a cardiac output and mean arterial pressure solution of 80 and 5, the intersection point can be heart failure or hypovolemia. And I submit to you that those are the exact opposite diseases. Well, don't panic. We can actually infer great information. Every picture I show is real, by the way. This was a picture I took from a scuba diving boat coming back. And I'll give you a bit of that cell there is actually about 10 kilometers behind the island, but I was driving, but it looks really good right there, right? Okay. We can look at ventricular pump function and venous return together at the bedside and assess cardiovascular state in a holistic way. As Starling showed, if you increase right atrial pressure, you increase cardiac output rapidly. And I showed you that in that first graph where they turned up the pump and the stroke volume went up. And you can then plot an immediate increase in cardiac output, which I'll call Q or flow. And this is a Starling curve. And let's assume that my normal CVP is 0, as everyone in this room's CVP is 0. Okay, that's a normal CVP. CVP is not 5, 10. Your CVP is 0 because it's the back pressure to venous return. And if you were to look at your pressure, if the CVP goes up, it decreases venous return because you don't have a pressure back. Why would you want to do that in the real world? Okay, so Guyton decided to look at venous return. He bypassed the right heart, took all the blood, and put it through a Starling resistor, which was a collapsible tube right here, pumped the blood out, and he wanted to measure the relationship that he got using the Starling resistor between changes in right atrial pressure and changes in cardiac output. And this is a picture from his original paper in 1957. We already knew the ANRAP effect, etc. This is the other side of the equation, the venous return. And what he found was very interesting in these dogs, that if he raised the right atrial pressure high enough so that the pressure out in the periphery, which we're calling mean circulatory filling pressure or mean systemic pressure, and the pressure in the right atrium were equal, there's no pressure gradient. If there's no pressure gradient, there's no flow. So the zero flow intercept of right atrial pressure is mean systemic pressure. So as you can see in the graph, in these dogs, the mean systemic pressure was somewhere between 6 to 12 millimeters of mercury. That's pretty low. And since your CVP is normally 0, that means that in you and I, we have a driving pressure for our entire cardiac output from the veins back to our heart of 8 millimeters of mercury. But that's enough because the resistance to venous return is so low that 8 millimeters of mercury is more than enough to get your venous return back. Okay? The other thing is, if the pressure in the chest becomes more and more negative, as for example you breathe in against an occluded airway, the pleural pressure becomes negative, the transmural pressure on the vessels becomes highly negative, and the veins collapse, and you flow limit. So we have a maximum amount of cardiac output venous return. Those are synonymous terms. Cardiac output is venous return. 100% of the blood coming back to the heart gets pumped out every time, no matter if you're in heart failure or in shock. 100% of cardiac output is venous return up until the moment you die. And so what you can see here is that flow limitation at the top means that the only thing I can do is hurt the body. So if this is my venous return curve, so as I increase my right atrial pressure, my cardiac output goes, the slope of this line is 1 over resistance, or conductance, if you will. And so the steeper the slope, the less the resistance, the flatter the slope, the more the resistance. And the intercept point is the mean systemic pressure. So if you extrapolate down to 0 flow, that must be where the two are equal, okay? And this was known in 1957, so this is not new information, and this has been validated many times, and I'll show you the human data that we published validating this as well. And of course, venous return is cardiac output. By definition, they are the same. And they're equal to this pressure gradient, the driving pressure for venous return, divided by the resistance for venous return. So we can explore the basis of cardiovascular physiology now, not from the heart in a pre-Copernican world when the sun revolved around the earth, but from a Copernicus world in which the sun revolves, we revolve around the sun. The periphery determines cardiovascular function. The heart is the handmaiden of the circulation. It is the periphery that determines cardiac output. If I were to give you a bolus liter of saline and measure your cardiac output 1 minute later, what would it be? The same as it was before I gave you the liter of saline. Because in you and in I, the determinant of cardiac output is metabolic demand. What will increase is not your cardiac output, but your urine output. Because that's what the body will do. It'll redistribute the blood and then try to diurese. If you don't believe me, try it. When you do dobutamine sampling in patients in the cath lab, and they want to just see how dobutamine will change contractility, they look at its changes in insystolic elastance and ejection, but the cardiac output with the dobutamine challenge does not change. The heart rate goes up, the heart gets smaller, but the cardiac output, because there's no change in metabolic demand. The reason you have a cardiac output is to meet the metabolic demands of the body, not to subserve some goal that we are gods. Okay? So, what we want to look at is cardiac performance, mean systemic pressure, and the resistance to venous return. So if I have my ventricular pump function curve, I can superimpose upon it, because it's the same axes, the venous return curve. And there's an intersection point, which we're going to call the equilibrium point. And it says that in you and I and every patient, there exists one and only one right atrial pressure and cardiac output that we can have, which is a balance between ventricular pump function, circulating blood volume, and blood flow distribution. And this is the world that we live in no matter what. And these are the things that we're going to affect with disease and anesthesia and mechanical ventilation. And they are the primary determinants of all the changes we see. It's really that simple. And I'll show you how that works, because it's really neat, because we can apply it at the bedside, we can apply it in the operating room. Okay? So let's assume that I have a normal ventricular function, which actually be a little bit steeper than that, but it's hard to draw a picture that looks pretty. And then all I do is I impair ventricular pump function. I will see a decrease in my Starling curve. And by the way, I published this in 1984. So I'm sure some of the younger people in the room were not even born yet in 1984. So we can comfortably say, if that's there, they're over here, we can comfortably say we knew this before you were born. Okay. So what happens if I impair ventricular pump function. I see the CVP go up and the cardiac output go down, right? Correct? That's exactly what you see. And what does the body do? It senses a decrease in cardiac output and it stimulates an increase in fluid retention such that the volume in the body increases, and as your effective circulating blood volume goes up, mean systemic pressure rises, and you generate a new venous return curve. You can do it by volume infusion. And now what happens is CVP is higher, but now cardiac output is normal. And you call that congestive heart failure because of the congested fluid. I call it congestive heart success because it's the only way the body, without us around, can maintain cardiac output in the setting of impaired ventricular pump function. So let's look at how these things work. Mean systemic pressure has two primary determinants: static ones, the amount you fill in and the volume and unstressed volume, and dynamic ones, which is blood flow distribution and resistance. And both of these happen, and these are the primary determinants of cardiac output and its change as you go from sitting to standing, as a patient gets hemorrhaged, or as you breathe, or as you give anesthesia. So, if this is my normal venous return curve, okay, and we'll say that in this case it's 6. By the way, in human beings, when we measure, it's around 11 to 12 is the mean systemic pressure we see. In dogs, it's 6, but ignore that. If I simply were to give you hypovolemia, there'd be less volume in the tank, and I'd have a decrease in the mean systemic pressure. And if I volume load you, I will have hypervolemia and have more volume in the tank. And please note on this graph that if I were to put a ventricular function curve in, for the same CVP, I'd have a different cardiac output in all 3 of these states. And it would be the same ventricular pump function for the same central venous pressure, right? I haven't changed physics. This is just the way it is. This is one of the primary reasons why you can't use CVP to determine volume status. Well, I can do the same thing with vasomotor tone. Since it's a bag of vasculature, this venous vasculature that has tone in it, if I have normal vasomotor tone and I simply vasodilate the person, then for the exact same blood volume, I have a lower mean systemic pressure and cardiac output falls. You can call that nitroprusside infusion if you wish, because that's exactly what will happen. Or I can give a vasopressor, phenylephrine, and increase my mean systemic pressure, but in that case, my cardiac output also falls because of the increased afterload. And I don't want to go into it, but my statement is please don't use phenylephrine, period. You should use norepinephrine if you want the blood pressure to go up. And there's absolutely no logic in ever giving a phenylephrine infusion. If you want to give a bolus of it once during induction of anesthesia, you can do anything once for a short dose and it won't hurt anyone. But if you have to keep doing it, please use norepinephrine. I finally got Stanford to not use phenylephrine anymore, but I can't get my own hospital to stop. Okay. So how do you measure mean systemic pressure? Well, many years ago, Guyton said that what you can do is you can do a total circulatory arrest and open up an arterial venous fistula, and in 5 seconds, the equal pressure between the arteries and the veins will be mean systemic pressure. Well, that's not very realistic. I can't do that well, and except in one study from Penn many years ago in humans in the cardiac cath lab, it's never been done in humans either. So I reason that if you were to raise our intrathoracic pressure slowly over about 3 seconds and look at the rise in CVP and the fall in right ventricular stroke volume, that you would get the same curve. Adrian Vespula said that Michael PINSKY has to be wrong because of capacitance of the vessels, and what I want to do is do an inspiratory hold maneuver at various spots so that the capacitance of the veins is constant, and that would work. You need a mass, instead of the 2 of us are correct. In 2009, she actually said, "Are you guys still correct?" And so we said, "Yes, we are." And she said, "Why don't we do this in humans?" So she repeated it in humans. Another way to do it is to model this Guyton curve with capacitance, resistance, and then you can measure, if you know you assume the capacitance, the resistance of the arteries and the veins, you know cardiac output, right atrial pressure, and CVP, you can, on a breath-by-breath basis, determine mean systemic pressure. And then finally, you can simply stop flow in the periphery, and at the instant you do it by rapid stop flow, at 15 seconds in, the arterial and the venous pressures become equal, and that pressure is also mean systemic pressure. So let me show you the way I did it originally. In 1984, we had a slow inspiration, and you can see that the airway pressure rises, causes pleural pressure to rise, causes CVP to go up, cause the stroke volume to fall. So you plot the decreasing stroke volume with the decreasing right atrial pressure, and you get what we call an instantaneous venous return curve. And I gave volume, and we get a different one. And if you gave volume, you'd say, well, you're just going up a Starling curve here, which is correct. We estimated the mean systemic pressure, and then we did a stop flow ventricular fibrillation, open AV fistula, and that's the red point. And so we were pretty close. And in fact, when we did it on all the animals, they had pretty nice values, and their relationships between our instantaneous mean systemic pressure on the y-axis and the gold standard stop flow on the x-axis was pretty good. We were happy. But as I told you, Adrian Vespula said, I don't think you're right. He was in Rotterdam, I think. I don't even think he's still alive now, is he? I don't know. But Jos Janssen is still, and he's about my age. And but Adrian was the physiologist at Rotterdam. So what he said is, well, here's PINSKY's inspiratory low flow, and as you can see from that, you get a decrease in your right atrial flow and an increase in filling. And he compared it to a series of inspiratory hold maneuvers in which you get a steady state increase in CVP and fall in right atrial pressure. So he does an inspiratory hold of 2.5 centimeters, 5, 7.5, and 10. Very minor, and waits for the equilibrium. And to his surprise, he got the exact same values that I did when he compared the two to each other in the same study. And so he then said, it looks like PINSKY wasn't wrong after all. And by the way, he's a friend. And this is some of the strongest validation you can have when people try to disprove you and find that you're correct. But the fact of the matter is that this technique is easier to do because it's very hard to measure pulmonary artery flow accurately on a beat-to-beat basis unless you have echocardiography. But it's very easy to measure steady state flow. So I can capture this approach and put it to the bedside. So with Yanita Moss, we went into human beings, and these are cardiac surgery patients, and we simply measured at the top. You can see the instantaneous stroke volume using the model flow technique, which was the original pulse pressure contour analysis method that all the other techniques, Pulse-CN, LIDCO, FlowTrack use. This is the father of all of those. This is the one that started it. And it's still very accurate and it's still around. It's called model flow. And you can see the instantaneous beats to beats, and you do an inspiratory hold for just about a couple of minutes. You get a nice steady state CVP and pressure, and that's one point. You get a series of them, and based on that, you can measure the mean circulatory filling pressure or the mean systemic pressure. And so in this example in humans, post-op surgery, cardiac, we had a baseline value with the CVP of about 22. And we then did a head tilt maneuver so that we were having a hydrostatic challenge with venous pooling in the periphery, repeated the numbers and it fell, and then we gave volume loading and it rose. And so we were able actually, for the first time in human beings in an intact circulation, without fancy instrumentation, to measure mean systemic pressure in humans. When I get through this, I'm going to then tell you that you can use this to assess cardiovascular state. But let me show you some more data first. The other mechanism was simply to use Guyton physiology and say if in fact the capacitances and the resistances of the arteries and veins are known as about 20 to 1 capacitance and 24 to 1 resistance. Okay, it's just physiology. And you can then do a calculation, and based on Parkin and Leaning's studies, you can calculate mean systemic pressure every end expiration when you have a CVP, cardiac output, and right atrial pressure. And when we calibrated that against our inspiratory hold, it had a slight bias, but in fact, if you simply multiplied the numbers by 0.7, they were equal. But more importantly, if you looked at the degree of change in mean systemic pressure across human beings, this is humans, versus the actual end inspiratory hold, the dynamic changes were very accurate. So using this method, Maurizio Cassoni at the University College London, using the inspiratory, PMS analog, gave volume to patients postoperatively, 500 or 200. And he found that when he gave it to them, their mean systemic pressure rose. And then after about 15 minutes, it came back to normal, which is exactly what you'd expect in a non-hypovolemic person. The body redistributes its blood. But then he asked the question, did cardiac output go up or not? And so to look at that, he looked at the driving pressure for venous return, which was the mean systemic pressure minus the right atrial pressure. And he found two groups of patients. those in whom, when he gave the fluids, the cardiac output increased, and those in whom he gave the fluids, the cardiac output did not increase. And in the group that the cardiac output increased, the driving pressure for venous return went up. And the group in which the cardiac output did not increase, the driving pressure for venous return did not. This is why we have a stopping rule for fluid resuscitation. If you give fluids and the CVP goes up by 2 millimeters of mercury, stop, because you are not volume responsive. I'd prefer for you to figure it out beforehand using dynamic measures, but if you're going to give volume and the CVP goes up, the body is telling you it's not volume responsive because it doesn't go up in you and in volume responsive people. It stays at 0 and the cardiac output goes up. Okay? So that's an application you can use immediately. Okay, now when I told you that when you change vasomotor tone you get a shift of the venous return curve, well, I kind of lied. You also change the slope of the curve, because if you go from flow in the inferior vena cava to flow in the superior vena cava, you have a lower resistance. Why? Because the inferior vena cava has to get blood flow through the liver as well, so you have a double resistor, the normal venous flow. So if I simply have all my blood flow going through the splanchnic circulation, it takes a lot more blood in the body to have a good cardiac output. But if I cause vasoconstriction of the splanchnic circulation, I get a shorter circulation time and I get more volume back. So how I distribute the blood flow by changing the resistance to venous return for the exact same blood volume will change the circulation. Okay? And the example here is the inferior vena cava or using skeletal muscle. So if I start jogging and I start using my skeletal muscle, which has very low unstressed volume and has a very short circulation time because of the low resistance, I can have a cardiac output increase by 5-fold in 10 seconds, which is what a bunny does to run away from a fox, or a fox does to eat the bunny, because otherwise both would starve or die. Okay? So you need to have this dynamic response to occur. It's not normally seen at rest. And so the point here is that for the exact same CVP and blood volume, I can increase cardiac output by shifting blood from one compartment to another, from a very compliant, high resistance one to a very low compliance, low resistance one. And that's how the body alters cardiac output instantaneously when you stand or when you eat meals. So when I look at the venous return, remember I showed you that if I had an increase in vasomotor tone, I would shift my mean systemic pressure to the right to a higher mean systemic pressure. Well, that's true. But since I've increased vasomotor tone, I've decreased the resistance. So the slope goes down. I'm sorry, I've increased the resistance, so the slope's gone down. And the same is true with vasodilation. As I vasodilate, I decrease the resistance, so the slope goes up. So it's a combined effect when you use vasodilation or vasoconstriction of changes in tone, but also resistance. And you'll see this with using norepinephrine, and I'll show you that data in a second, and propofol, which is what you wanted me to talk about. Okay? And they are going to work under these principles. So the first person to show it, and we predicted this at the time, was my very good friend Jean-Louis Taboul from Paris, in which they had septic shock patients who were on norepinephrine and they were stable. And he decided that it was okay to take them down on their norepinephrine because it was time to wean them off this vasopressor agent. And so he measured their instantaneous venous return before decreasing norepinephrine and then after taking them off the norepinephrine. And as you can see, to nobody's surprise, the mean systemic pressure decreased from 32 to 22. Obviously, you've decreased vasomotor tone. You're going to have, for the same blood volume, less mean systemic pressure. But the cardiac output didn't fall half as much as you thought it would because the resistance to venous return decreased. So for a lower driving pressure, I had a higher flow because I had less resistance. That's really good. That really is a good thing. You want that. Okay? And in fact, with GERTS in animals, we looked at the effects of dobutamine on cardiac output. Now, dobutamine on its own should have no effect on cardiac output. It only changes contractility. But in heart failure, it can increase cardiac output. Why? Well, it affects the resistance to venous return on the arterial side, but also on the venous side. And if we focus in only on resistance, you would see that dobutamine is a vasodilator. If you didn't think dobutamine is a vasodilator, give your hypovolemic patient dobutamine, and they'll become profoundly hypotensive immediately. Trust me, this is true. If you don't believe me, do it yourself, and you will see what I'm right. But the other side, why does it increase cardiac output? Well, let's focus in on venous return. And if you do, you would see that if the primary problem is blood flow, dobutamine cuts venous return down by 1/3. So in a volume overloaded state in heart failure, not only are you increasing contractility, but you're markedly decreasing venous return, and it is that combination that causes cardiac output to go up. And so you can see that if this is your ventricular pump function, this is the picture we used in our paper, and that's your venous return curve under normal conditions. If all you did was increase contractility alone, you'd see a slight increase. Remember, you were in heart failure, so you had a little bit of play on your venous return. But if you were to give dobutamine and then cause the venous mean systemic pressure to go down, but the resistance to go up, you go to a new ventricular pump function, and you see that in actual fact, the cardiac output's much higher than it would have been from just increases in contractility in its own. Okay? And that's what dobutamine does. I want to stop for a second now and talk about arterial pressure flow relationships, because there's sometimes confusion about this, and there shouldn't be, because in 1960 we already knew that there's a zero flow pressure. If I were to take anyone, you can do this right now yourself. You have a patient in the operating room and you have a radial artery catheter in, okay? Quickly take your hands and squeeze the forearm quickly to totally stop flow. What's going to happen to the arterial pressure? First, the pulsatility will go away, but does the pressure go to zero? No. It goes to like 40 millimeters of mercury and stops. Don't believe me? Do it. Tell the nurses you're doing it ahead of time, because they might get upset. They think the patient's died. But do it. And what you'll see is the pressure drops to this level. That's the critical closing pressure. That's the pressure at which point, when the arterioles have tone and the pressure inside them is less, they spontaneously collapse down. Okay? And that was shown initially by Burton and Stinson, in which they talk about the pressure at zero flow. And they hypothesized, Saul Permit, my mentor, showed that in fact what happens is you decrease pressure, the periphery compensates to maintain autoregulation and vasodilates so that the critical closing pressure becomes smaller. And for those in the class who took my advanced physiology course, like Jan and Andre, they're painfully remembering this. They're still going through therapy for having taken these courses. Okay, and so if we look at arterial resistance, and this is a paper by Milnor, the great physiologist from Johns Hopkins in 1978, you can see that the arterial pressure and the pulse pressure don't change very much until you get to the arterioles, and then it falls. So let me rephrase that. There is no arterial resistance. There is no arterial resistance. If there was, why could you measure mean arterial pressure from a radial artery catheter? It would have a pressure lower than your heart. It doesn't. It's the same pressure. If it's the same pressure, there's no pressure drop. If there's no pressure drop, there's no resistance. Isn't this a true statement? Good. It is. Now let's think about what I said. A normal stroke volume in a healthy person's around 80 mLs, maybe 100 if you're a big guy. Okay? Every time the heart beats, 80 mLs come out. You with me? So how much is 80 mLs? It's about that much. Let's take an empty aorta and fill it with 80 mLs. It won't get past the second innominate artery. It won't. Think about what I just said. I'm not inventing this stuff. So every time you have a heartbeat, you're just charging the capacitor. The reason you see it if you cut the aorta is it's decompressing and it squirts out, just like water squirts out of a balloon if you put it in it. Okay? So the point is that every time you have a heartbeat, you're charging this capacitor, and it's then discharging across the arterial circuit. All the resistance is in the arterioles. arterial resistance is clearly not uniformly done. So in collaboration with Jose Marquez, somebody you know very well, we went into the operating room in human beings and put a flow probe on the aorta and arterial pressure, and then we measured the gold standard arterial pressure as we then put our finger on the inferior vena cava. And for the first time ever in human beings, we measured left ventricular stroke volume with the gold standard and arterial pressure. Obviously, this was right before going on cardiopulmonary bypass. But you cannot believe the IRB consent form that I had to have. It took us 3 years to recruit 6 people. But we did it, and nobody got into trouble. But now I had, for the first time ever, real stroke volume and pulse pressure in human beings. And when you do that, you see that in human beings in the operating room, they behave as if they have a critical closing pressure of 20 millimeters of mercury. That's their vascular waterfall. Their CVP at the time was 2. It had nothing to do with this. This is the back pressure to flow in these patients. Okay? It's a vascular waterfall. And what it means is the flow over Victoria Falls is a function of the height up there times the edge there. It could care less how much it falls down. It could fall down 1 foot or 1,000 feet. The rate of flow will not change once it gets to the waterfall. The critical closing pressure is the vascular waterfall. Okay? Okay? I don't know what that's supposed to say. But by the way, that's me. Oh. Yeah. So in connection with Manita Mas in our ANA paper, we actually measured not only venous return, but left ventricular output in the same patients, in human beings. And we showed not only the venous return curve using the inspiratory hold, but simultaneously the mean arterial pressure. And you can see that the critical closing pressure for the vasculature in you and I is around 35. And the mean systemic pressure in this example was 20. So the vascular waterfall was 20 millimeters of mercury between the two. But arterial resistance is extremely low. Okay? And I can change mean arterial pressure by 2 mechanisms. Change the conductance by changing the slope, or shift the mean systemic pressure back and forth. And I shift the mean systemic pressure back and forth more often than not with drugs and with sepsis. It's a lot harder to change the slope. For that, I need nitroprusside. Okay. Otherwise, the slope's very hard to change on arterial resistance. But I can shift the mean systemic pressure, the critical closing pressure, very rapidly. And you know that is true because hypotensive patients who, when you give them volume and they get their cardiac output go up, are simply having a fall in their critical closing pressure because the slope is fine. Okay? And in fact, this is what we saw in our patients. If you looked at systemic vascular resistance, which was the green line, or whatever the color that line is, it has no relationship to arterial resistance in these humans. Okay? And that's why I never report systemic vascular resistance. In fact, arterial and venous resistance are much, much smaller than systemic vascular resistance, and they're controlled by different mechanisms, and the body controls both. So now let's use this clinically to talk about what happens when you give propofol, which is something that some of you may give. This Gertz and his group here in the Rotterdam, north of here just a few kilometers. I think that's where it is. Or is it northeast of here? East of here. They took 17 patients with general upper abdominal surgery, and they measured the cardiac output using the model flow technique, because this is the one we all had. I have it too. I use all of them. And they calculated the mean systemic filling pressure using that inspiratory hold, which you're all now familiar with, right? Okay? And then they gave propofol at 3 levels, small, medium, and large, based on BIS. I'm not a big fan of this score. It was developed in my lab by, what's his name? I'm blocking on his name. The guy who went to then Penn and then to New York. Never mind. Mark Bloom. Yeah. Mark did that in my lab. And it was really, the interesting thing about it was he was doing it in the lab, and we were changing his level of anesthesia, and he said, I got to change this equation. I said, you're changing your equations based on the anesthesia level, not on physiology. He says, no, it's no physiology here. I'm changing it so that the equation fits what I see. So is there any surprise that if you change anesthetic, BESS might not work? Okay, it was done as a total phenomenological effect, and he fully admits it. Okay. So anyway, they used BIS, and these are, you would expect, these are relatively, and this is continuous infusion, Mike, so this is not bolus stuff we're looking at here. And they measured mean arterial pressure and CVP, and from that they could calculate everything. And this is an example from their paper of one of their inspiratory hold maneuvers that gave them the mean systemic pressure. And as they gave higher doses of propofol, they saw many things happening. Number one, the mean systemic pressure fell, the mean arterial pressure fell, but the cardiac output remained the same. So as you can see in this picture, the mean circulatory filling pressure started at somewhere around 28 because they volume loaded these supine patients, and it went down to about 20. Okay. The mean arterial pressure was 82, 75, 66. All right? Nobody in the room should be surprised so far, right? You with me? What happened to the cardiac output? Okay? Well, the cardiac output started at 5.7, 5.8, and 5.5. Was not changed at all. And the mixed venous O2 sat was not changed at all. How did that happen? How can I give propofol, seeing my mean arterial pressure fall and my mean systemic pressure fall, but the cardiac output doesn't change? How does that happen? What could be the mechanism by which it worked? Well, it worked because as they vasodilated up the periphery, they had a marked decrease in resistance to venous return. Also decrease in arterial resistance, which was much less than seen in the mean arterial pressure. And this counteracted it, such that when they plotted the cardiac output between the two, this mean CVP went down a bit, but with the high propofol, the resistance to venous return went down. And so what they had is they had truly balanced anesthesia. So in my accompanying editorial, what I said is that using these minimally invasive techniques, they could understand the physiology of their patient at the bedside. They were able to derive the driving pressure for venous return and resistance, and they were also able to measure arterial resistance, and they showed it decreased much less than systemic vascular resistance. And that using this approach, they could find that propofol creates a truly balanced anesthesia, in which though you have a decrease in left ventricular myocardial demand because of the decrease in stroke work needed, you maintain cardiac output to your patient. Okay? Let's take one more thing and then we'll call it. We did another study in Rotterdam in which we had patients who were getting left internal mammary arteries to their left anterior descending coronary as a part of a cardiopulmonary bypass procedure. And the surgeon in this case was very concerned that normal hypotension seen in the post-op hearts was bad, and he wanted us to increase mean arterial pressure by 25 or 30 millimeters of mercury immediately post-op for a couple hours. Yes, sir, we said, and we said, we'll make our measurements, not a problem. So we used norepinephrine and increased mean arterial pressure. And we did. And what we found was that cardiac output increased mean systemic pressure, and it increased left ventricular afterload. And so we used stroke volume as a surrogate of it. What we found was in half the patients, cardiac output went down, and half the patients, cardiac output went up. What turned out happening was those in which the cardiac output went down had no pulse pressure or stroke volume variation. They were not volume responsive, and the increase in afterload impeded cardiac output because of the fact the left ventricle wouldn't eject again. And the other half, who had a normal pulse pressure variation, when they had the norepinephrine increase in venous return, they could handle it because they had increase in stroke volume. This is identical to you being the anesthesiologist in the operating room in which they cross-clamp the abdominal aorta. If the person's a healthy young person with trauma, their cardiac output will go up as they increase venous return. But if there's my age and you cross-clamp it, an elderly person, their cardiac output will go down because of the increase in afterload. Okay? And what they found was that in the 16 patients, we had the increase in mean arterial pressure, mean systemic pressure went up, right atrial pressure went up slightly, resistances all went up, and cardiac output decreased in some and increased in others. And the reason it did was because of the stroke volume variation. And you could actually see it. The ones who the cardiac output increased, they had an increase in mean systemic pressure and right atrial pressure, as you can see. In the ones the cardiac output fell, they had the same increase in mean systemic pressure, the same change in norepinephrine, but they had impaired contractility. And you could have measured it. And you would have seen it by the increase in the pressure gradient for venous return, mean systemic pressure minus right atrial pressure. Okay? So what I've given you is 2 concrete examples of how using totally non-invasive techniques at the bedside, by measuring mean arterial pressure, cardiac output, and CVP, you can determine the effects of norepinephrine in the 2 studies and propofol and impute what's happening to your patient. We can take this much further in the future, but these are concrete examples of applied physiology that was published over 50 years ago, as it's now finally being taken to the bedside in the operating room. With that, I thank you for your attention.
Thank you very much, Michael. That was heavy stuff. I'm not sure you had everyone in the room with you, including me, for all the story. Are there questions now? Okay.
By the way, nothing I've said hasn't been published within 30 years ago.
Eric Jensen speaking. So pressure monitoring is one of the most common hemodynamic monitoring. Cardiac output monitoring is used less. If you could only use one, which would you prefer if your monitor could only measure pressure or cardiac output?
Okay. Well, first of all, I'm going to call this a fool's choice. I would measure pressure first because hypotension will always cause hypoperfusion. And with a sudden decrease in blood pressure, I'll decrease cerebral and coronary blood flow. And so in the instantaneous changes that need to be monitored during anesthesia, I need to know pressure, because if the pressure falls very low, even if the cardiac output's fine, I'm not going to perfuse the heart and the brain. Hypotension abolishes autoregulation. I don't need to have sepsis or anything else. If I have hypotension, I can't get blood flow to my organs. So if I had to choose one initially, it would be blood pressure. But if things do not work when I have blood pressure, I would measure flow. And I will reverse the question. If the easiest thing in the world to measure was flow, and the question was, do we really also need to measure pressure, we'd be having the exact same argument. Okay? So the answer is it's easier to measure pressure than flow, and since a sudden fall in pressure will always decrease flow to the heart and the brain, I want to know that right away. But if my patient does not respond appropriately to my initial treatment, you absolutely have to know what's happening to flow. And in fact, we made that a position paper in the European Society of Intensive Care Medicine, and it is in our position statement for the American Society of Anesthesia's Enhanced Recovery After Anesthesia document, for which I'm one of the co-authors. Because specifically, if they don't respond immediately with standard resuscitation efforts, you should measure flow. And if everybody here measured flow, we would stop using phenylephrine. Because just as Mike showed in his study, if you give a person a phenylephrine infusion, it decreases cardiac output. So you must be causing decreased blood flow to the body. So you shouldn't be focusing only on pressure. You need to focus on pressure for the first minute. But after that, the body doesn't live on pressure, it lives on flow.
Thank you.
Other questions? Bertolt?
Michael, thank you for your excellent talk. Just a question from a clinician. We believe for many, many years that propofol is also a negative inotrope drug. So your paper in the BJA shows that propofol is not negative inotrope drug, but it just decreases vasodilatory tone, so it's a vasodilator, only vasodilator?
Well, we have the ability to measure left ventricular end-systolic elastance and arterial elastance using the single beat echocardiographic technique. I do that routinely. But Gertz in Rotterdam didn't measure it because he doesn't know how to do echo. And so I called him up afterwards and said, let us repeat the study in which we measure left ventricular contractility. And he says, no, I want to go on to something else. So I went with another group, and we're measuring it now in another place. And we'll tell you the answer. But even if there is a slight impairment in contractility, understand that unless it's a major impairment, afterload reduction always wins in terms of maintaining ventricular pump function. Okay.
More questions? Maybe the question on preference for flow and pressure measurement is obsolete or becoming obsolete because now we have monitors that tell us what flow or cardiac output is from the pressure signal. So what's your opinion there? Should we dive into that, or now all have flow measured based on arterial signals and then never be confronted with that dilemma again, or is there more to that story?
I have a conflict of interest in that I've worked with every single one of the companies that make the pressure to flow signals, every one of them, and they've given me honoraria to lecture, but they all don't have me lecture now because I always tell the truth, and every one of them is giving an approximation of flow, but it's better than nothing at all. The calibrated systems, which is the Pulsion's Pico device and the Lidco Plus, are accurate, the most accurate. The uncalibrated systems, which would be the Lidco Rapid and the FlowTrack by Edwards, are less accurate. Also, the NICOM, which is the non-invasive cardiac output, is as accurate as FlowTrack, which means less accurate. They all tend to have changes. But what happens is when you start measuring flow in your patient on a regular basis, continuously, it totally changes your appreciation of what you're doing with your patient. Until you measure it, you have no idea what you're doing. And when you do, but you need a real-time measure, you realize what's going on. The best we used to do in the past was the continuous cardiac output by the PA catheter. Now, and for those of you who've ever seen one, it's not a continuous cardiac output. It's telling you what happened 5 minutes ago. Okay? So you can have a cardiac arrest right now, and it says the cardiac index is 5. Okay. So it's a great thing to put in the record for telling you what happened before when you want to finish up, but it doesn't help you for minute-to-minute management of your patient. For that, you need the beat-to-beat ones. The algorithms on these instantaneous minimally invasive are constantly changing as they're getting more and more accurate. The only one that hasn't changed is the Lidco because it's a power transfer function, and that doesn't change. So I've been a big fan of all of them. Like I said, the literature, and I've published this, many papers, comparing each to each in human beings. The two best are the Lidco and the Pico that are calibrated, but you have to calibrate them. It's no big deal. It's thermal injection, you look. But you have to calibrate it. But once you do, they're accurate. The others are approximations, but it isn't clear to me if the approximations are bad because maybe they're off by 20%. There is no such thing as a normal cardiac output. It's a non-existent term. Cardiac output is either adequate or inadequate to meet the metabolic demands of the body. What you care about is the change in cardiac output in response to treatment, time, or disease. And thus, these devices all track changes quite well.
But would you agree? You said if you don't, you can have all the measurements you want, but if you don't react to it and have physiology background, you may not have the result that you're aiming for, and it's just nice monitors working in the background. Mm-hmm. But I would take it one step further. If you have a monitor that does not accurately give you the number that you need to have, isn't that a risk of over-treatment or under-treatment? Even if it just indicates changes, those changes may be wrong.
Gotcha. Thank you for this question. There's two parts. When I wrote the book, Functional Hemodynamic Monitoring as a term, the very first thing we said in it is that no monitoring device, no matter how accurate its data, will improve outcome unless coupled to a treatment which itself improves outcome. So I don't really care what you measure. If you can't do anything about it, it doesn't matter to me. Okay, that's number one. The second question we also addressed in a position paper in critical care medicine on the monitoring devices, and what we said is trends, everything estimates cardiac output, nothing measures it presently, and that trends are much more important than absolute values, And that the advantage of all these devices are they show trends. But if you don't have a treatment algorithm in your mind that is going to be personalized to that patient, then knowing these data is meaningless. In my final lecture of the day, if any of you are still here, okay, I'm going to talk about improving outcome in high-risk surgical patients using precise, personalized resuscitation using these methods. So I'll go into it then. But with regards to the question, if you don't know what you're doing, it's not going to be good. But when you're talking about inaccurate, if the cardiac output says it's 7 or 5, to me it doesn't matter. And that's the level of its accuracy. But if it goes from 7 to 5, it is accurate because it has gone down by 25%. Okay, so that would be
You say that the algorithm behind that calculation of flow, that trend is always right. It's not so that the algorithms can indicate a decrease, while in fact there's an increase going on. Because
Well, they
sometimes
don't-
I see physiology reinvented based on what these uncalibrated monitors.
Well, okay. There's a thing called concordance in which you use
Yeah.
a polar plot. And when we plot each device to each other, they tend to all go in other directions. But if you look at the same device and you do increase or decrease cardiac output with a balloon in the inferior vena cava or something, so you know for a fact it's happening, or you put a gold standard flow probe on the aorta, as I have done many times, they all trend in the right direction. The slopes of those trends can be different, not based on the catheter, but based on the state. So in a septic vasodilated state, some of them over and some of them underestimate the change.
Okay.
And that's true. So the algorithms change the slopes. They don't change the directions.
That's the answer I was fishing for. More answers?
You have a question right here.
More questions? Yeah.
So, I mean, sorry, I'm a bit jet lagged, came from the U.S., but I'm thinking about this as where the rubber meets the road. So you've got a 58-year-old male who's presenting to you whose BMI is 65 for surgery, non-compliant with CPAP, severe pulmonary hypertension. Anesthetizing these types of individuals is always very, very precarious. How would you go about that in terms of your thinking of cardiac output and knowing what the right? Would you do a tilt test on this type of patient to see if any sort of preload, like if you were to put them in?
No, I
valve
wouldn't.
Or,
I don't. First of all, we do tilt tests all the time, and I was part of the original authors of those papers. But in the patient you mentioned, which is a pulmonary hypertensive patient, the major fear you have is systemic hypotension causing acute cor pulmonale. And so you must start the treatment, the pre-induction medicine there, if you're in Pittsburgh, is epinephrine, and for me it's norepinephrine. So the first thing you start, and this we actually did an ASA, a session on pulmonary hypertension. How do you treat it? And the very first thing you do is before the induction of anesthesia, you start a low dose of norepinephrine. And then as you induce anesthesia, you maintain the blood pressure with norepinephrine, not phenylephrine, because you want to maintain cardiac output and ventricular pump function. And once they're stable, then we use transesophageal echo to assess whether or not they develop paradoxical septal shift. And if they don't, you can give fluids until such times as they're no longer volume responsive if you want. But the goal is not to volume load you until you're no longer volume responsive. I think somebody else is going to be talking about dynamic parameters after me, and he'll be going through them. That's pulse pressure and stroke volume variation, which you can measure very accurately in the operating room. But if you think that they're hypovolemic, their SVO2 is low or their arterial venous CO2 gap is low, but if they're otherwise stable, you just want to keep them there. I did anesthesia on a 78-year-old woman with a hemoglobin of 6, with severe aortic stenosis and pulmonary hypertension, who needed to have an hour-and-a-half endoscopy to stop a bleeding gut because they couldn't operate otherwise. Had to intubate her and stabilize her. We put in a central line first, started the norepinephrine, then we induced anesthesia, intubated her, and maintained her pressure with the norepinephrine. We didn't put a PA catheter in, though I was about to. I didn't, but I should have. In the old days, I would have put a PA catheter because that would tell me what the mean arterial pressure should be versus the PA. But we guessed it hadn't changed. And we were able to have a perfectly stable state for 90 minutes. And when they were done, we turned off the propofol, and extubated her in 10 minutes. She said, "How'd it go, Doc?" She was fine. Okay.
Did you induce with a bolus of propofol? Or did you just
Yes.
start the propofol? If you did bolus,
We used the bolus.
would you use a transthoracic echo? Ever take a look?
We
to
used
see-
the transthoracic echo to
Okay.
start, but we
Okay.
didn't do it
Gotcha.
continuously. The only thing I can ever do continuously is transesophageal, and I didn't have one available with me. They were in the other room. But if I'd had it, I'd have put it in. I love transesophageal. Is so easy. You know, transthoracic's hard.
All right, thank you very much. Two excellent talks. We have a